Good morning, everybody. My name is Mark Cubitt, and I'm a member of the Chapter Committee of AIDEN, the Australian International Development Network. I'd like to start by acknowledging the traditional owners of the land on which we are all tuning in from today. For me, I wish to acknowledge the Wurundjeri people of the Kulin Nation. We pay our respects to the local people, their elders, past, present, and emerging. At AIDEN, our message is simple: more and better giving and investing from Australia to international development. And one of the ways we are going about that is by showcasing and amplifying the work and issues in the sector. Today's topic, the COVID emergency in India and Nepal. It's reported daily by every media outlet. However, one reason for putting together this briefing is that our members wanted to hear what is really happening on the ground. Media Watch tells me there's only one Australian reporter based in India, James Oaten of the ABC. And that country ranks below Myanmar and Afghanistan for press freedom, according to Reporters Without Borders. We have a lot to cover in the session today, so let's dive right in. The Q&A and chat functions will be operating today, so please send through your questions as they come to mind. So firstly, I'd like to introduce Anuba Rawat, who will be facilitating our session and moderating the questions. Anuba will do her best to get to the questions in the last 10 minutes. Anuba is a projects director at the DAC Foundation and a board member of Partners for Equity. She has over 20 years of experience working across South Asia and Sub-Saharan Africa in the international development sector. At DAC Foundation, Anuba works across a wide range of programs and is passionate about program development and initiatives that are championed at the local level. I'd now like to hand over to Anuba.
Thank you so much, Mark. So good morning, good afternoon, and good evening to you all. We've been joined by panelists and audience members across several time zones today. Just a sober reminder of the COVID crisis in India, with over 400,000 cases a day and 4,000 deaths a day last week. There is, and this being a massive undercount by experts, there is no family I know that hasn't had to deal with the distressing and sometimes tragic consequences of COVID. Across the border in Nepal, case numbers have risen by about 1,200% in a matter of weeks. Case positivity is at about 40%. My country of origin is facing a disaster of epic proportions, and that carnage is spilling across the border to a country close to my heart, Nepal. We have quite a lot to cover in this 1 hour. So in the interest of time, we've divided the webinar into two parts. The first part is going to deal with oxygen and oxygen access, and the second part is going to deal with the fallout of the pandemic in rural urban India and Nepal. I'd now like to introduce my colleague, Mani Rikards, the Operations Director at the DAC Foundation. Mani leads the medical equipment program here at DAC and has been involved with oxygen and oxygen systems for several years pre-COVID. She has a detailed and nuanced understanding of the issues around oxygen systems and the challenges to get oxygen to patients. So Mani, to start us off, oxygen has become such a common term in this last year through this pandemic. But it's quite confusing in terms of how oxygen is produced, what are the challenges to get it to the patients. Can you give us that 101 explain on what it really is?
Okay, thanks, Anuba. I'm just going to talk about the oxygen technology piece and leave the local response to the other experts on the call. So over the last 10 years or so, DAC has supported oxygen programs in a number of countries, including Laos, Nigeria, Mali, Papua New Guinea, and Malawi. This has given us a few insights. We'll start by talking about which patients need medical oxygen before we even address COVID. So the top 5 or so are neonates, especially preterms, kids with pneumonia. Pneumonia is the biggest preventable killer of children under 5. Surgery, ICU, maternity, acute respiratory illness, and now COVID. So there's a lot of conditions there. Critical COVID patients need much higher volumes than, say, a child with pneumonia. So a child with pneumonia might need only 2 litres per minute. A patient in surgery, maybe 8 to 10 litres per minute will do. A critical COVID case needs 40 litres per minute. So that's a huge amount. Generally speaking, around 5% of confirmed COVID cases will be critical. Oxygen will be the difference between life and death. These critical patients may need oxygen for 14 days. Another 15% or so of cases are classified as severe, and many of them will need oxygen for up to 7 days, but they might survive on lower flows or less litres. Oxygen itself is typically delivered to the patient in one of three ways. It's piped to the bedside from a plant or a tank that's on site at the hospital, or the patient is directly hooked up to a cylinder that's next to them or an oxygen concentrator. It's the scarcity of medical oxygen that's the big issue in India. The production and the supply can't keep up with the demand. And this is not unique to India and Nepal. In very broad strokes, this is due to a lack of planning and chronic underinvestment. In fact, oxygen was only added to the WHO essential medicines list in 2017, despite being used clinically for 150 years. Some LMIC governments still don't even see it as a priority beyond COVID. A pre-COVID study in Nigeria indicated that 80% of patients admitted to hospital needing oxygen don't receive it. So I'm going to take a step back now and talk about how the oxygen is made and why it's not so easy to quickly ramp up the production. There are two types of medical oxygen sources, and you would have seen these mentioned in the media lately. The first one is liquid oxygen. Liquid oxygen is produced by a molecular separation process using cryogenics. So it's called oxygen separation. Liquid oxygen plants are really expensive to build. They're usually commercially operated and owned by one of the large gas multinationals. Many lower income countries have no local production capacity. They can only import it. So India has production capacity, Nepal does not. So when the borders close, that creates a real problem. The liquid oxygen is put into special cryogenic tankers. Again, these are very expensive. And then they go and refill the big storage tanks on the grounds at major hospitals. Liquid oxygen can also be used to fill cylinders after it's returned to its gas form. But this happens at the site of that big plant. The second process, and we'll talk a lot about this, is the oxygen concentration. And this is where room air is filtered through zeolite crystals to remove the nitrogen, and it leaves a higher purity oxygen, around 93%. This technology is used in those small bedside devices called oxygen concentrators, as well as small to medium oxygen plants that can be built on site at the hospital. They are called pressure swing absorption, or PSA plants. They can produce, from 100 to 1,000 litres per minute, depending on the size. But 1,000 litres per minute is not much. When you're looking at the crisis in India and Nepal, it's only enough to treat 25 cases at 40 litres per minute. The great thing, though, about this technology is that it can be plug and play. Bedside concentrators are the size of a suitcase, so they can pretty easy to transport. They can be delivered and treat a patient straight away, as long as there's a power source to plug into. A small PSA plant can be pre-built on pallets or in a shipping container, and it can be installed on site in a short period of time. Most of the discussion around the oxygen plants you'll hear today will be about these PSA plants. PSA plants can be piped through a hospital or used to fill cylinders. And it's not just production, there are the barriers to supply, but I know my time is low, so I'll quickly go through them. It's the lack of cylinders themselves. It's the long delays to refill the cylinders at the commercial plants. People are waiting in line for days. Consumables like nasal cannula, PPE, insufficient workforce, people are down with COVID. And there are limitations to the bedside concentrators. They can only produce about 5 to 10 litres per minute, but a critical case needs 40 litres per minute. But very importantly, these lower volumes of the oxygen concentrators can still help prevent severe cases from becoming critical. So concentrators can free up the ICU beds. Patients need less oxygen as they recover. Another key tool are the pulse oximeters. And these are the devices they clamp on the fingertip and they measure the oxygen levels in a patient. This is how the ICU staff can prioritise who gets oxygen. So putting oximeters in clinicians' hands will save lives, even if there's no increase to the amount of oxygen that they can access. I haven't touched on ventilation here or the issues around repairs and maintenance for sustainable oxygen, but if we get time in the Q&A, we can address those questions. Thanks, Anita.
Thank you so much, Mani. That was really great. So the most important takeout really is oxygen was already at scarce supply pre-COVID, and COVID has simply exacerbated that need hugely. I'd now like to go across to India to introduce you to Dr. Pravin Kobragade, who is a health specialist at Unicef India. Pravin has over 20 years of public health experience, and he's coordinated several health sector responses for Unicef, including tsunami assistance and the Zika virus. Dr. Pravin, when we last spoke, you spoke with great urgency about the need for oxygen in India being huge, huge, huge. Um, can you give us an overview of the situation in India on the ground at the moment, and what UNICEF India is doing to tackle that situation at the moment? I'd also like to say that Praveen only has a very short amount of time with us, so we can potentially take a couple of questions after he has finished speaking. He has other pressing matters to deal with. Praveen, over to you, and please unmute yourself.
Right. First of all, let me thank Dark Foundation and as well as all those who have been able to organize this event. First of all, let me inform you that it's a unprecedented crisis which I have never seen in my life. Every day, some of the other known person to me, either a relative or a friend, or their their parents, I hear that they are no more. You know, we get condolences message from either on the social media or on emails uh, daily, which was not the case earlier. India is now contributing to the highest number of COVID new cases daily. You know, in fact, if you add the rest of the world's COVID cases, daily COVID cases, India has surpassed that. You know, in fact, around 400,000 new COVID cases have been reported daily, which is the highest for any country. No country has reported such high number of daily COVID cases. And as I said, if you add all the rest of the countries in the world, their COVID cases numbers daily, India is over that. We have around 4,000 deaths, which are reported deaths, and I will say reported. There is tremendous underreporting right now. I'll just give you an example, which was reported yesterday. Around 40 to 50 bodies which were decomposed and which were bloated were washed away, were found on the banks of the river in one district, which is Buxar district of Bihar yesterday. And we fear that these were all COVID cases, all COVID. There is there's a custom, especially in one part of the country, where if someone dies, their bodies can be actually submerged in the river for them to attain what I'll say moksha. So the uh, the situation is quite overwhelming. At the same time, we are facing vaccine shortage. You know, around 2 million vaccine doses were being administered per day, but yesterday it was only 600,000. Why it is? Because there's tremendous vaccine shortage in the states. The production capacity is limited. So the susceptible population for COVID continues. However, we in UNICEF, we have been partnering with the government and around 150 local organizations in the country across sectors. I'll say it's not like I'm in the health sector, but we have other sectors as well. For example, wash sector. We have a tremendous another section which is known as communication sector, which is supporting the government in its communication to the general public. And we in the health sector, we are partnering with the medical NGOs, with such as Doctors for You. We are partnering with local medical associations, the state chapters, the the district chapters. At the same time, we have been supporting right from the start. That's from last year. And however, this year, since the need of the oxygen is tremendous, I'll also tell you, the last year and this year, if we compare the wave, this year's wave is 4 times to that of last year. We had around 100,000 cases per day. That was the peak. And here for this year, we are around 400,000 cases almost daily. So we are tackling a very unprecedented situation. Our oxygen capacity production is around 7,400 metric tons per day, but that is not enough. Daily and daily, we are getting more and more number of cases. We need oxygen at the earliest. If we in UNICEF could supply around 3,000 oxygen concentrators, we need around 15,000 oxygen concentrators right now. That's what we have estimated. There is a huge pouring of international aid. In that sense, we have now estimated that at least from UNICEF, we supply around 15,000 oxygen concentrators. We have placed now orders for only 1,000 oxygen concentrators. We are also supporting in what Madni has just said, in establishment of the oxygen generation plants. 74 oxygen generation plants, which are the PSA oxygen generation plants, we are supporting, and we are in the advanced stage of installation in 25 locations. In the rest, we are at various stages of supply and installation. At the same time, the diagnostics in India is also has also taken for a hit. Almost every fourth or fifth test in India is positive. The test positivity rate is around 20 to 25% on a daily basis. That means that many of the positive cases have been missed in India. The test positivity rate should be at least 5 or less than 5%. Here it is 20-25%. What we are now preparing is that since India has authorized vaccination for more than 18 years of age, however, the vaccination coverage is low. We hope that the vaccination situation improves. However, our pediatric population will be susceptible for infection. We are also in a phase of preparing our pediatric facilities. And for that, what we need is high flow nasal cannulas. We need oxygen concentrators, be it 5 liters. Usually for an adult, what we'll need is 10 or 15 liters per minute of oxygen concentrators. For pediatric, even 5-liter oxygen concentrators will be required. We are identifying those pediatric facilities. We are trying to map out at the district level and sub-district level what are the pediatric facilities and what is the gaps. So I'll request Australian people, if at all you can support us, please do support us. Like, it's an unprecedented situation, and as I narrated, a situation of the bloated bodies which were found yesterday in river. That was only yesterday. Day before yesterday, it was in another state, which is in Hamirpur town of Himachal Pradesh state. There also there was some bodies which were found. So there is massive under-reporting. There is and the needs are tremendous. Even if there's a small contribution, it will be of much help to us.
Dr. Pravin, thank you so much for that insight. And, just kind of the media reports you read, you wonder if it's true. And actually, what you're telling us is actually more than what we're seeing in the media. I don't know if we have any questions for you, but if they are, we'll email you. Dr. Pravin heads the COVID pandemic's response from UNICEF in India. And he's really busy, as you can imagine, and, hear from him. As he's mentioned, what they do need is financial support, and some of that we'll talk to towards the end of this webinar. If you have any questions, please pop them into the chat question box now, and if he stays on for a bit, we can take a couple of questions. If not, we'll answer them to you via email. Dr. Pravin, thank you so much for your time and for that kind of shocking insight into something that we're not seeing sitting here in Australia. Now, moving on from oxygen, I'd like to invite our next panelist to kind of shed some light on what's been happening at the community level in India. So to start, I'd like to introduce you to Dr. Pankaj Chitwani, the co-founder of the Breakfast Revolution, an organization based in Mumbai to tackle malnutrition. They provide nutritious, locally sourced breakfast to women and children, and aiming to also really influence public policy decisions around malnutrition. When Mumbai became the red zone last year through that first wave, Pankaj and his team had to really use their resources quickly to start distributing meals to daily wage earners, women and children stuck in slums in lockdown, and people who lost their livelihoods literally overnight. They've since distributed over 6 million meals in that time. Pankaj, you and I have spoken, at length through this time, but can you give us and share some insights with the rest of us in terms of how your team has had to respond to the COVID crisis and, what you're doing now in preparation to these new challenges that are coming up?
Absolutely. Thanks, Anubha, and thank you for organizing this. You've kind of summed up what we do better than I would, so thank you for that. The situation is pretty bad, as you can imagine, as Dr. Pravin alluded to. We're seeing only the tip of the iceberg is being reported. There's a whole lot that's not being reported, and the situation on the front line is something we've never seen in a lifetime, and I think we'd be fortunate if we never have to in the future. A couple of lines, just that we all have relatives, friends, patients, hospital administrators, politicians call, WhatsApp message about need for beds, about need for concentrators. A lot of that has been discussed and has been reported. There's a separate side that has been underreported for obvious reasons, and that is that at least where we operate, mainly in urban areas, about 80% of the population are daily wage earners. So what that means is they're outside the formal workforce, and in order to earn every day, they have to work every day. And the days they don't work, they don't have food, at the end of the day. So when when the first wave of COVID happened, we kind of evolved our program to, serving school meals, serving fortified school meals that address malnutrition. Schools were shut down, and the community was in dire need for food. We pivoted the model as you described to serve, the emergency at that point. Had a lot of help and support from government agencies in order to make sure that our food is being manufactured in large quantities, that it's being allowed to be transported to different sites, to like densely populated slum areas, and also being supplied. So we did a few things that are true even today. We abandoned our everyday school meals because there was no schools. It was high risk to reach out to families every day. We turned to a model in which we bulked up meals, served them to the entire family as part of like monthly meal boxes. Each box had hundreds of meals packed in them. Not only were they fortified, ready to eat meals, we also supplied dry ration as part of our work. And then we also included multi-nutrient supplements so that women and children get the micronutrients they need, especially during the time of stress. So we were able to do this at scale. We did about 100,000 deliveries of food to organizations we work with, served about 120,000 individuals, about 7 million odd meals over the last few months. And the work continues. The work, we're faced with a challenge where families are down to 1 meal a day, sometimes, and sometimes, in remote instances, no meals at all. And there is no out, right? There is no out in the lockdown. There's no opportunity to earn a livelihood. And we're just fortunate to be able to work with government agencies, with local hospitals, with, about 100 plus local community-based organizations to deliver something that is so fundamental, just a meal a day for families. Yeah, so it's very disheartening. It is it's a crying crisis. And what's been the silver lining is just the amount of support that has poured in from world over. Anubha, you and DAC have been instrumental right since the beginning of COVID to facilitate hundreds of thousands of meals. We've had donors in the US, and then thousands of individuals signing up to contribute, be it 5 meals, 10 meals, 100 meals, 1,000 meals, etc. So just very fortunate to see the public support that has come from all over the world. But I think the way this might shape out, and Dr. Pravin's here and would love his inputs as well. This is not something that will be resolved in a couple of weeks, in a month, in a couple of months. This has kind of scarred the public health system, scarred a lot of the livelihoods and it's going to take several months for the country to recover. Appreciate all the support that's pouring in. And I think right now is the opportunity to give, and it's less relevant who to give to and who you're giving to and where you're giving. It's just the important thing is to give to thousands of grassroots level organizations who are doing their best. So that's a little bit about what we're witnessing. I was I don't remember the first conversation that I had with you on about several months ago. Now that I look back at things, probably boasting that we do so many deliveries every single day. Not a single person has tested positive in our team because we're using PPEs, we're using social distancing. Unfortunately, we've had about 15 people test positive just in the last week, and we've had a bunch of people who we can't even test. So things have changed. We're evolving quickly to make sure that our food supply is still in place. And there's a lot of work to be done in the coming months.
Yeah, thank you so much for that, Pankaj. It really is kind of, last year we thought, early this year we thought maybe we were coming out of, this wave, but the second wave has really hit in a massive way, and left a lot of people unprepared. But your team has obviously had the experience from that first wave, so I've been able to adapt. So it's been really impressive watching as your team has kind of faced all of these different challenges. We do have one question. I'm just going to stop because Dr. Pravin is still with us. Pravin, a question for you is, how do we get more PSA oxygen units into the affected areas in a really short amount of time? Because, it takes quite, from our experience, it takes a while to kind of set up a PSA plant. What's your how's UNICEF dealing with that?
See, it takes at least, right now the markets are full. The suppliers are also working day and night. In fact, one of our supplier is not even going home. His employees are sleeping in the manufacturing unit. So that's the amount of unprecedented crisis which even the suppliers are now facing. And there's a huge demand. The suppliers are not been able to meet those demands. So ideally, if you look at the sequence of events, what happens is that first a site needs to be ready for accepting the oxygen generation plant. We just can't go and install an oxygen generation plant. There are certain safety norms which needs to be followed as per the Government of India guidelines. So earlier what used to happen is, and that's what we also faced, say in January, February, March, is that there was a tremendous delay in site readiness from the government side. So like it took months for them to get one site ready. But now what is happening is it just takes a week for them to get ready. And whereas that time the suppliers were ready with the supplies, and this time it's totally opposite. Where the government is ready in a week, here the suppliers are taking months for. So I think it's all now lopsided. So we don't have a ready answer. I'll just give you an example that out of 162 PSA generation plants which were sanctioned by Government of India, only 32 were supplied. I'll just give you one example of how Even the suppliers are constrained. So there is a no ready-made solution. It's not an off-the-shelf product that we pick and then we install. It's not like that. The PSA oxygen generation plants for installation has to take into consideration many factors. For example, the altitude. If there is a higher altitude, then the compressor has to be of high capacity, etc., etc. So taking all this into consideration, even from the PSA oxygen generation plant side, it's a constraint. But even then, if we start now, you know, what we feel is that there will be a third wave which will be coming. So even when we invest now, it's a preparation for the third wave. Also, what we feel is that the third wave will be hitting the children more. So it will be for a preparation for the children.
Okay, thank you so much for that, Dr. Pravin. Now I'm just kind of moving on from that kind of urban India context, and I'd like to introduce you to Anshul Gupta, the founder of Goonj. Goonj is an organization that was set up to tackle the huge amount of middle class waste that Indian cities accumulate and redistribute that to people in need and in times of emergency. They not only have collection and distribution centers, but they partner with village communities to initiate community development initiatives across India. Goonj are present in 25 states and about 150 districts in India, and were really well placed to support the massive fallout of the strict lockdown in last year in India, where people were given only about 4 hours to return to their homes. So Anshu, can you tell us a little bit about how your team has had to deal with the COVID crisis last year? And now that the cases are beginning to surge across rural India, what is it that you're facing at the moment?
Thank you, Anubha, the foundation and all. So I think I'll just build up on what Dr. Pravin and Dr. Pankaj said. Fine, they referred places like Buxar and Hamirpur, and on the basis of that, I'm just trying to unfold the disaster. So if you see last year, the crisis all of us thought is hunger, because those millions of people we saw walking on the roads. So suddenly, food kit became the focus, and unfortunately, it was only limited till the point those guys were visible. The moment they were out of borders, we actually forgot that more than half of India, 70-80% literally, because I also consider slums a part of rural India. I never consider slums a part of urban India. Slums are never the extension of cities, because if slums are the extension, people like me and you should have gone there and stayed. Slums are the extension of the villages, because they are the places where the people who are the victim of forced migration actually settle down, and that is the reason they start walking back the moment something like this happens. So we ignored that entire rural India part last year. This year again, the crisis became oxygen and bed and all, and largely in the cities to start with. Now it is a much bigger disaster in rural India, which is absolutely not reported, because in any case, rural India for this country unfortunately does not matter. Okay, otherwise, how can you find these 40-50 bodies in just one small place floating in a river? This year again, the focus has become the health and the oxygen, absolutely rightly so, because that is the need of the hour. And we have now ignored the hunger part. Right? And hunger is actually becoming a much larger disaster, because what we need to understand that even if last year it was a big disaster, we all know, in terms of hunger and the food security, food safety. This year it is a top-up disaster. It is in continuation. It is not a fresh disaster. So last year, even if people had little bit of capacities to fight with it, this year people do not have. And then there is a second wave of reverse migration, where people have years back they came to the cities in desperation. Last year they walked back, then they came in the hope of job, they somehow settled down, and now again they are back. They're not visible because the buses are going on and we are not reporting from the bus stands and the railway stations, but millions of people have gone back, and unfortunately this time they've also gone back with the diseases, and that's how it is reporting, because that's how it is spreading. So and also we do not have the basic infrastructure of health in the villages. You can imagine, if Delhi and Mumbai couldn't handle it, the places which have the most expensive private hospitals to the government set up, how will you really tackle this disaster with a small PHC which does not even have the basic medicine or the doctors? So what we are trying to tell people, that is extremely important to treat the hunger part also. millions and millions of people again need those food kit, or what Dr. Pankaj was talking about, the food. I mean, imagine for last 1 year, the schools are closed, the Anganwadis are closed. And one of the biggest thing for these schools and Anganwadi used to be midday meal. And now those millions and millions of kids are not getting that even small midday meal, which used to be the main attraction and main need of those schools. Right? And then, so one is the hunger part. We are also working on oxygen to whatever, like any other, institution in our own capacity, right from WhatsApp to the larger import and whatever. But I'm just not touching upon that because other people, have already touched upon, on those issues. What I'm trying to say is that we all need to be prepared to deal with the food part in a very, very big way, nutrition part in a much bigger way, very basic health facilities. If we can equip people, I don't know how much we will be able to handle the second wave in, what Dr. Pravin also said, but at least be prepared for the third wave, and at least be prepared to save as many people as we can. Right? There is also one angle, which is the missed out communities. So Goonj has a vertical of missed out communities. And when we say missed out communities, it is basically people with disabilities, sex workers, transgenders, people with leprosy. Now, unfortunately, artisans and artists also, and the musicians also, because for the last 1 year, there has been no show. And the musician does not do anything, apart, that's what his or her core efficiency or core work. So the lead singer might survive for some time, but the person who was on harmonium or banjo does not have any mean to survive. And with that pride, it's extremely tough for them to really, go and ask for something. And I'll give you a very simple example how we missed out issue. So we were just, convening this meeting of the people who are working on these verticals, because we work with almost 500 partner organizations all across the country. These are the grassroots organization, medical organization, all kind of organization, and units of Indian Army, border road organization and all. So when we were talking about the people with leprosy, which we have a lot, almost 800 colonies, which are not even reported, they said that people last year died more, not just because of lack of food, but also because they didn't have access to the cotton bandage and the basic medicine. Because people with leprosy, the first important need is a regular bandage. So when the bigger issues happen, when the macro issues happen, micro of million is missed. We also have a very effective, health delivery system, which is the ASHA worker. Right? If nothing else, they can at least decide on people who need to be isolated, but they do not have even an access to a thermometer. So some of the things which we are trying to do, which we are already doing, large part of food work, that too with the help of local people. So last year we channelized almost about 5 million kgs of dry ration, but a large part of it is also which we were procuring from the villages instead of transporting it from the city. So 250,000 kgs of fresh vegetables. So you just don't insist on rice, flour, whatever is available locally, because that supports the nutrition, that supports the local economy, and that is an easy distribution of material without burdening the logistics. So food is important, extremely important. Basic healthcare, where you can actually just give 2 oximeter, what you also said, 2 oximeter, couple of thermometers, and a small basic medical kit which can go to a health worker, and that person can decide at least in the basic thing. And then converting as many rooms, as many schools possible into basic isolation centers. Okay, and then equipped with those things with the medical stuff and all. But at least, because large part of India, like many other countries, live in one small room. 6 to 8 people, 5 people stay in one room. So that is the reason that there is no way that if one person is affected, the other family members will not be affected. So I think I'll stop here. It's all about missed out communities. It's all about hunger. It's all about equipping the people with the local basic health facility, because, Anubha, remdesivir is a life-saving drug for me and you. But a large part of the country still needs crocin. How many of our villages, our small towns are actually ready with the 1,000 pieces of crocin in one go? And 70-80% of us who recovered, like me, I also recovered. I got it in May last year itself in the first wave. We all recovered because of those 3 times crocin in a day. So that's what we really need to understand for 70-80% of population of this country. In addition to all those big things, which are extremely important because the crisis has become so big and so deep this time.
Yeah, thank you so much for that, Anshu. It is really distressing to hear about the lack of basic needs, let alone support for COVID patients across, the areas that you work. Just for everybody's information, crocin is paracetamol, which Anshu was talking about here in Australia. Anshu has won several awards, notably the Magsaysay Award for transforming the culture of giving in India. And Anshu, I really thank you so much for your time today. I know you're also extremely busy with trying to coordinate all sorts of things across the partners that you work with. I'd now like to move across the land border to Nepal and introduce you to Surya Bhatta, the Executive Director of One Heart Worldwide. One Heart Worldwide partner with the government to upgrade maternal healthcare facilities, and they provide training to the staff to provide the needs of the community. They work in about 16 districts and 146 municipalities across Nepal. Surya also sits on the steering committee of the international NGOs in Nepal and represents the health working group at the government level. So Surya, we've been working with you for several years now, but can you tell us a little bit about how One Heart Worldwide has had to respond to the crisis last year in Nepal and what you're having to do now in this situation right now where cases are surging in Nepal at the moment? And unmute yourself, Surya.
First of all, thank you everyone for this opportunity to speak with everyone, Dak and Mark, in ADN team, everyone. So yeah, the situation in 2020 was very different than now, though it's COVID. People were really worried about the overall situation. It just started from the west and coming to the east. Then it got all over the world. So earlier the situation was very different in terms of the fear public like response was pretty strict, and they are blocking even people coming from one village to another, people going from city to village. So that was a pretty good in terms of restricting the disease or restricting the virus. We were able to really work with the Ministry of Health and other partners, and also our support all around the world. There are two things we did last year. The first thing was how can we better respond to the people in the need, because our primary beneficiaries are moms and babies. They are not, and their families are not seeking the healthcare from the health facility, and so we really need to make sure that all the service providers are protected. They have a necessary PPE and all the infection prevention measures, all the basic supplies like a thermometer, everything. So that time the big problem was supplies of the PPEs, and we really had to struggle with getting those supplies because China and India are really our major source of the all the supplies, food supplies, medical supplies, and everything. And so China was struggling a lot at that time. So there was a huge crisis of getting the PPEs, and everybody was calling and asking where we can get the supplies. And One Heart is really involved in a lot of medical supplies support into the rural birthing center. So we literally ran to every store we used to purchase our medical supplies, and we collected everything possible they have in their store, and then we really donated whatever we could do to the ministry. And that's really how it began our response. And then later on we started to really frame out what is really the needs. We worked with the government to identify the needs, plan A, plan B, plan C, so depending on the how case goes out. And so based on that, we were able to really get some of the supplies in joint consortium. So myself and the Care in Nepal, the two of us really led the joint procurement of the PPE with rest of the international NGOs working in Nepal. So that gave us the like some opportunity to provide our extended support and joint effort to get the supplies from the market. So we were able to deliver basic supplies to every municipality, the quarantine isolation center quarantines, and as well to the health facility where our moms and babies are coming. And on top of that, we also started the teleconsultation helpline, so because we wanted to reduce the not necessary visits or on, only do the essential, services in the health facilities. And we did not see the, actually any drop into the service utilization. We actually noticed the huge increase on service utilization into our health facility, because large hospitals were actually, closing the services, blockade. And so they could not travel, and, travel restrictions, there is no service availability. So a lot of, those, people who would go to the big hospital, district hospital, actually started going to the nearest birthing center, and also people from the city actually move out to their village. So, that's really how the situation unfolded, and, slowly situation got better. We were able to really provide the, larger support at the national level, as well as to the, our, health facilities where we are actively working. And right now, it just follows the same story in India. This is not very different, but it just started later on. India and Nepal shares the porous border. There's people keep going and coming. So they estimate that around, for 100,000 people are, traveling around here and there in every month from Nepal and India. Even though there is a, government is trying to really have some policies and, procedure in the border, but that is just unstable with India. So, it slowly started with, the border of the India, like a very, middle west Nepal. In Nepalganj, that's where the, first, SARS was seen, and then it started all over the country. And mostly, right now, what is the difference between India and Nepal right now is, yes, the population wise, it's a huge country, and we can imagine that. But in Nepal, even though we are seeing around 10,000 cases per day, and Marnie already mentioned that 240, 1200% SARS in a week time. So we are seeing around 47% test positive. That is the highest in the world. So that was really the case. And we feel like, right now, the testing is so underreported. A lot of rural areas, district level, they don't have a test facility. So people are just, not going to the test, means you don't know the problem, and they're, spreading all over. They're having waiting, they're having a lot of, ceremonies going on, and we can see the pictures in the Facebook, like people are, so there's a lot of communication gap we are seeing, on top of, lack of medical infrastructure out in the field, out in the district where we're working. And of course, oxygen, is a big deal. And Nepal is heavily dependent with India to getting a lot of oxygen supplies from there. So, we just have very little, sources right now. We do have a, good capacity of the, oxygen, manufacturing, but the lack of, cylinder is just a big challenge right now. So people are not getting the oxygen, and, the bed is full, all same story what India is going through right now, but the test is just so, like terrible. So everybody is like, what is the next? How we are going to really deal with this situation? And on top of that, our political fallout is also coming out, because we just have, the Prime Minister lost his motion of confidence yesterday. And so there is a political crisis going on along with the COVID crisis here in Nepal.
Okay. So yeah, that's a lot for you all to deal with at the moment. We continue to watch anxiously as the situation unfolds in Nepal. And as you said, while you might have good production capacity, the geography of Nepal is very different from that of India, and providing oxygen cylinders and concentrators is a process in itself. I'd like to mention here that actually the situation continues to escalate across South Asia. There are case numbers rising in Sri Lanka. Potentially Bangladesh is going to be next, but we simply don't have time to cover all of that today. So we've kept it to India and Nepal. I do have a few questions that we can now go to some of the panelists. This question is for Dr. Pankaj. And the question is, has the average cost of food risen through shortages and opportunism over this last year? What have you seen?
Yeah, so we've seen about a 20 to 25% increase in our costs, our raw ingredient costs. Some things like soy, it's less steep. Some things like cereal, it's other cereals, it's slightly higher. Sugar is higher. We're also seeing, thankfully, we have some long-term contracts that just saves us from some price fluctuations, but we're seeing across the board 20-25% increase in cost, at least that much.
And so that obviously then translates to people living in slum communities and the villages. I'm sure also will be facing similar issues with not having jobs, but yet having food costs rising to a point where they can't afford it. So food is a huge issue to continue to focus on.
Absolutely, and unfortunately, we are also dealing with the the most expensive diesel and petrol right now. Every day in the last few months, it has just gone up, and that's what we don't understand. That the moment the diesel cost goes up, it is all about the commodity. It's all about the common people who suffer. It's not about the people who hire a cab. That's how people. That's how the politicians talk about it. That people who are affected by all these increases are only the people who own car. Even people who own car suffer in any case. But I would say that because we have seen it in the last 1 year or so, the cost of transportation has gone up like anything. And that obviously increases the complete cost when it happens at the delivery point. So it's not only about cost of food, and then there are a lot of so-called unwanted and unnecessary material is added in your life. So now everyone needs a few masks. The basic cloth mask prepared by whatever kind of cloth in the smallest possible market is for 20 rupees, 30 rupees, and the entire family needs it that way. Sanitizer, which we never used that way. Right? I mean, it was just simple soap we used to do. These have become the necessity of life, unfortunately. So the bill in any case of every single home is increasing day by day. And then of course there is black marketing, there's all kind of nonsense which opportunists in any case do that, because disaster is one of the biggest opportunity for the people who want to make money. Okay, we've seen it in all the disasters. I mean, today Oximeter is really till last year even I didn't know what is Oximeter all about. Oximeter ranges anywhere between 500, 600 rupees to 2000 rupees. And it's a small plastic box. We don't know what is there in it. And that is one of the riskiest thing in our life right now. The moment you see that number, you're gone that way. Emotionally, you're gone if it just goes down certainly. I think all those crises people are facing, and medicine, we are very, very worried, right? Because a lot of these small places, unfortunately, get a lot of fake medicines. In many countries, including India. So we are really, really worried that how do you channelize these basic medicine like crocin and multivitamin from the bigger cities and procure it at least from the genuine source. The prices have gone up of medicines also like anything. If you compare it, the same bottle, if you pick up of throat cleaner, something liquid, that is actually gone 2 times, 3 times. So all the medicine cost has also gone up. And of course, there is a risk that if you buy it locally, what kind of thing people will get in the name of medicine, we don't know. So these are just insights for millions and millions of people.
Yeah, and these are stories that we're not hearing here at all. So, it's really sobering what you're talking about. I'm going to ask a question to Dr. Pravin right now. It's, people are asking about when to expect the third wave, and can you give us some more details around that third wave? And is it because of under 18s not being vaccinated, or what's some of the reasons around that sort of expectation of the third wave arriving and when it might arrive?
Yeah, so I'll start from the first wave, and then I'll come to the third wave. If you look at the first wave, then it was mainly those who were highly exposed to the virus, or those who were elderly, that's more than 60 years of age, okay, and those who had comorbidity. Now, when this population, that's the healthcare workers or the frontline workers, have been vaccinated, so the susceptibility of them has come down. At the same time, more than 60 years of age population is also been getting vaccinated, so even their susceptibility has come down. The phase of more than 45 years was also introduced for vaccination. And then now what has been opened from 1st of May is that adults what we are seeing right now in this wave is more of that earning population. Those are which I'll say the youths, or that kind of a population, which is, I'll say, from 18 years of age to 60 years of age. We are seeing more cases in that population right now because they were not vaccinated or they were susceptible. Vaccination has started in, though it at a very, very slow pace. You know, if you look at the population size, then it's triple. It's three times more to that which were the elderly population. Now, when I come to the susceptibility, then what is left is those which are less than 18 years of age. And the virus is smart. The virus also wants to survive. So the virus then tries to invade in those population where who has not yet developed antibodies, or what we say is the susceptible population, and that population is children. And hence we feel that the next wave will perhaps be where the children will be affected, will be directly affected more. Right now there are children which are being getting indirectly affected. There are many orphans right now, many orphans, just because the parents have passed away. But the third wave, what we feel is that it will be the children who will be directly affected. At the same time, vaccines have not yet been approved for children, so they are more vulnerable.
Dr. Pravin, are children at the moment, are you seeing more pediatric cases with severe COVID at this point, or this is in anticipation that you're preparing for?
Yeah, see, as I said, in the first wave, there were around 100,000 cases at the peak, and now we are seeing, like, if there are 100,000, we are seeing 4 times more daily cases. Now, when this has increased, the proportion of children has also increased, and so this is the phenomenon which we are seeing right now. It's I'll say uh, it's not that the children are getting more infected. I'll say it's within the entire caseload. If the children were say 10% were of them in the first wave, even this time it's 10%. Okay, but the numbers are more.
Yeah, got you.
Yeah.
Emily Gribble, this is a question for you. Can you kind of talk to us a little bit about the quantity of PSA plants on order for Unicef India?
Yeah, sure. And Dr. Pravin, please feel free to interrupt me if I've got any of it wrong. But as Dr. Pravin said, we've got 25 oxygen plants in advanced stages across hospitals in India. Our target was 50. For context, these are about $180,000 each. Additionally, to support oxygen supplies, we've had 3,000 oxygen concentrators, diagnostics, medical kits and other critical equipment that's arrived into India. We've got 2,000 more oxygen concentrators that will arrive by the second half of May, with another 2,650 that are being procured. We've sent additional critical life-saving supplies, face shields, surgical masks, and in order to try and understand the flow of this, and does this wait till funding arrives, that our teams in India, we have bridging funds that we access. We have to reach into budgets from next year, and all that sort of thing will have knock-on effects. So the message from our team is that the more funding comes in, the more they can purchase, the more they can get the systems in place. And in particular with these oxygen plants, roughly around 28 days for these to be installed. So the quicker the money comes in, the quicker we can start putting them in the hospitals, and the quicker we can prepare for this third wave.
Thank you. There's also a question on how NGOs, big and small, are working to get together to coordinate this increase in need and unprecedented suffering. I mean, from what I can say is that, the Indian diaspora has kind of massively rallied, and there are all sorts of things being sent to India at the moment, like lots of money, oxygen concentrators, all sorts of medicines. They are being sent. lots of people, it's better to work with large coordinating mechanisms. UNICEF is one of them in India. In Australia here, we've got AIDEN and we've got a few other organizations that are kind of rallying to create some sort of consistency around how we respond to the crisis. But it is an emerging one, and South Asia is on high alert at this point in time, and the virus knows no borders. And we're seeing what's happening in Nepal at the moment. Bangladesh is currently not showing that many cases, but Eid is just around the corner, and people have already left to go to their homes from Dhaka, which is a densely populated city. So I'm assuming that in a couple of weeks, those case numbers are going to rise in Bangladesh inevitably. So, South Asia continues to be on high alert, and that's something I think something we should take away from this panel as to what we can continue to do to support. It's not a need that's going to go away. Medicine and oxygen concentrators on one side, but food shortages are huge, and basic commodities, bandages, paracetamol, things like that, as you've heard from the panel today. I'd like to thank all the panelists for joining us today and sharing all of these key insights with us. They're all really extremely busy people, and I'm so pleased that they've been able to come and spend time with us. I'd like to hand over to Emily Gribble, who is the head of philanthropy at UNICEF Australia, to wrap this session up for us.
Thanks, Anuba. Today's session's been informative and concerning all at the same time. It's continues to be evident that all of us are involved in this response, and we need to help in any way we can. And I can see from the chats, people are saying, how can we help? So if you feel like you're able to support the response in India, and I know some of you on the call already have, thank you. There are a number of ways you can do that. You can donate to UNICEF's appeal. You can discover the work of the Breakfast Revolution and Goonj by visiting their websites, as well as One Heart Worldwide in Nepal, who are supported by Partners for Equity. There are many organisations running appeals at the moment. Of course, please respond to the organisation that speaks to you. I'm happy to have a conversation with anyone who'd like more details on UNICEF's response. I can confirm that 90 cents to the dollar of all UNICEF's donations will go directly to the field, and at the moment we are remitting funds daily to the India team. We ensure that it will be the fastest, most impactful and sustainable response that's possible, so please feel free to call me at any time. Aidan will have further reading and links in the wrap up with this, so please do share this with your networks and anyone who's interested. Thanks, as Anuba said, to all our panelists. Thanks, Aidan, for providing this platform for a really informative and engaging conversation. And thanks to all of you who've taken an hour out of your day to be informed, consider the situation, and let's see if we can do something today together to make an impact in this crisis. Thank you.